Dear colleagues, dear ladies and gentlemen, thank you very much for this kind invitation. I want to talk about standardization versus individualization of EHS guidelines and the tailored approach for ventral hernias. I have nothing to disclose. I have no conflicts of interest regarding this presentation, and I will come up with three topics: the evidence and guidelines, the reality and controversies in the repair of ventral hernias, and the tailoring concept. What could it be? The group of surgeons, as you can see in this picture, is from almost all European countries, as well from America. And it was a great honor for me to be part of this consensus group. We met up in Amsterdam, Malmö, and Hamburg. And finally, we have published two publications. They are with open access. Everybody can read them. The guidelines for umbilical and epigastric hernias published in the British Journal of Surgery. And the second one is in BGS Open, the treatment for primary ventral hernias in rare locations in special circumstances. Both publications are published this year, and we have included a treatment algorithm. This treatment algorithm says normally, of course, you should choose always a mesh. In cases of lower than 1 centimeter gap, you could choose a suture repair as an option. What is the reality and the controversies? And of course, I just remember a publication or an editorial from Giampiero Campanelli, and he stated, of course, the ventral hernias are poorly clarified in case of treatment. There are open questions. What should you do in case of rectus diastasis? Is there a place for IPOM? Is there a place for any devices in ventral hernias? We have two more publications about the reality. One is from US, and the mesh procedures take the biggest part, yes, but 31% are suturing, almost in small hernias, might be, but also there seems to be a huge place for patches and as well for the IPOM and endoscopic repairs. In Germany, we have this year a publication in September about the hernia mate database and the reality of small ventral hernias seems to be totally different. We have 79% suture repairs and almost 94% open repairs. For an umbilical or epigastric hernia with a defect of lower than 1%, we have asked during the European Hernia Society meeting in Hamburg last year, and with the Survey Monkey during all the members of EHS and AHS. And finally, of course, most of the surgeons are suturing these small defects. In 75, 79%, they don't use a mesh in small defects. If you're doing an open mesh repair, you use any kind of patches. They are normally, of course, for intra-abdominal use. And once again, a surprise, yes, 58% of the participants of the European Hernia Society meeting in Hamburg say yes, they use patches. And with the Survey Monkey, we could find 36%, not even the flat mesh. But if you ask the question in a different way, do you normally use a flat periperineal mesh? Yes, Most of them are using them. I think it looks like there is a difference between the second question and the third question. Most of the surgeons are preferring a tailored concept, and they agree with recommendation regarding this. What's about the tailored concept? And the tailored concept is something which keeps a balance between standardization and individualized concepts. Umbilical hernias are very common, and the majority of umbilical hernias are in 3 different age groups. And of course, there is the question, should we treat them always in the same way? With childhood, after pregnancy or older age, most of the majority of defects seems to be small. And there are a lot of influencing factors. Classification is one point, age, comorbidities. The simultaneous rectus diastasis plays an important role, and the individual exertion or pregnancy. Finally, don't forget the wish of the patients. The operation techniques, of course, suturing is one option. Open mesh could be anteriorly, posterior with a knife bomb, or endoscopic with all the new techniques which are, I think, in favor of some of our surgeons. The material plays a second important role. We have, of course, the flat meshes, and secondly, we have a lot of pre-shaped meshes or patches. The mesh overlapping, what could it be? 3 centimeter, 4 centimeter, 5 centimeter. The fixation should be resolvable or permanent, and do we close the gap or not? So we have finally the option tailored concept is something which is related to the surgeons, and the surgeon has a huge impact. Of course, the own experience, key opinion leaders, their own school and economy, and of course the individual facilities plays an important role. You should keep a balance between, of course, simplicity, safety, education, cosmetics, comfort, and risk, complications, intra and postoperative recurrences, and pain. The summary, I came to the conclusion, I think we have a lot of multiple variables. The scientific evidence seems to be very low. In most cases, a mesh repair is recommended. Up to 1 centimeter suture seems to be an option. Standardization is needed, but almost for all these special techniques. And individual therapy is allowed, but you should always reflect your own quality. Thank you very much, and have fun with the MESH conference. Best regards from Berlin.